Arbovirus introduction. The arbovirus arthropod-borne viruses or RNA viruses that are transmitted by the blood-sucking arthropod from one vertebrate host to another. The inclusion in this group is based on ecological and epidemiological consideration. Hence, it contains viruses of diverse physical and chemical properties. Though taxonomically unacceptable, the name arbovirus is used biological concept classification. Arbovirus belong to the sixth family. Togaviruses, Flaviviridae, Bunyaviridae, Rioviridae, Rhabdoviridae, and Orthomyxoviridae. The arbovirus is caused by the following clinical symptoms such as febrile illness with or without rashes and arthralgia, encephalitis, hemorrhagic fever, and the characteristic symptomatic disease yellow fever. General properties: all members produces fatal encephalitis in suckling mice after intracerebral inoculations. The properties of arbovirus are shown in the table. Laboratory diagnosis of arbovirus. Diagnosis may be established by the virus isolation of serology or specimen. The blood, CSF, and brain may be used for the isolation of viruses. All arboviruses are viremic. The blood is collected during the acute phase of the disease. The CSF is useful in encephalitis cases, but the best sample is the brain. Virus isolation, suckling mice. The specimens are inoculated intracerebrally into the suckling mice. The animals developed fatal encephalitis. This is the most sensitive method for isolation of arbovirus tissue culture. Some viruses may also be isolated in tissue culture. Vero HBK21 and mosquito cell line are inoculated with this specimen. The growth of the viruses in cell culture is identified by the immunofluorescence, hemagglutination inhibition, complement fixation, ELISA or neutralization test. Virus isolation from insect vector and reservoir animals. Such isolations are important to know the identification of arbovirus activity in the area. Serology: using ELISA serotype specific IgM antibody may be detected in patient serum within 1 to 3 days after the onset of illness. The detection of a four-fold rise or more in antibody titer by ELISA complement fixation, hemagglutination inhibition or neutralization test also provide a good evidence of infections. Families of arbovirus. Togavirus morphology: viruses of the family Togavirus from toga meaning mantle or spherical 60 to 70 nanometer diameter with icosahedral capsid surrounded by the lipoprotein envelope and contains a single standard positive sense RNA. Classification: the Togavirus is the largest family of arbovirus. It contains two genera, alpha viruses and ruby viruses. The virus belong to this family are transmitted particularly by mosquitoes. The genus ruby virus, which contains rubella viruses, is not arthropod-borne. Viruses of Togavirus, alpha virus, mosquito-borne. Encephalitis group: Western equine encephalitis, WEE, Eastern equine encephalitis, EE, Venezuelan equine encephalitis, VEE. Febrile illness group: chikungunya viruses, O Nayog viruses, Simliki forest, Sinbis, roast river viruses, ruby virus, rubella virus, alpha virus, chikungunya virus. The virus is transmitted by Aedes aegypti. The disease is characterized by fever, crippling joint pain, lymphadenopathy, conjunctivitis, and rashes. The hemorrhagic manifestation are seen in some patients. The fever is typically biphasic. Chikungunya is a native word for diseases in which the patient lies doubled up due to the severe joint pains. There is no animal reservoir for the viruses. No vaccine is available. Flaviviridae. The generic name of Flavivirus has been assigned to the member of family Flaviviridae. Some members of the family are mosquito-borne, while others are tick-borne. Hepatitis C virus is neither mosquito nor tick-borne. Morphology: the virus of the family Flaviviridae are spherical, 40 to 50 nanometer diameter. They contains a single standard positive sense RNA. The mosquito-borne Flavivirus is encephalitis viruses, St. Louis encephalitis viruses, Ichthys viruses, West Nile viruses, Murray Valley encephalitis virus, Japanese B encephalitis virus, Japanese B encephalitis virus. The virus was named Japanese B encephalitis to distinguish it from Japanese A encephalitis virus, which was prevalent at that time. The virus is responsible for most of the serious illness among 5 viruses of this group. Pathogenicity: natural infection of Japanese B encephalitis occurs in Addis bird, heroines and herons egrets, and the virus spread from birds to birds through Culex rhynchus. The human infection occurs from these reservoir birds by several species of Cudicin mosquito. The heroine acts as a reservoir host, and pigs acts amplifier host. Other birds, ducks, pigeon, and sparrow may also be here involved. The vertebrate host may include cattle and buffaloes beside pigs. The high cattle-pig ratio in India has been suggested as a factor in limiting human infections. Epidemiology, it is widely distributed in China, Japan, Korea, Philippines, and Southeast Asia. Several outbreaks have occurred in Bankura, Burdwan in West Bengal, Dibrugarh in Assam, Gorakhpur in UP, Goa, Kolar in Karnataka, South Arcot in Tamil Nadu, Puducherry, and various areas in Andhra Pradesh. Sporadic cases have been reported from different parts of the country. This disease has become a major public health problem of national importance. Prophylaxis, the prevention measure includes mosquito control and establishment of piggeries away from the residential area. The foreign inactivated mouse brain vaccine has been reported for human immunization in Japan and in India also. 2 doses of vaccine are administered at 2 weeks interval, followed by a booster 6 to 12 months later. The immunity produced is short-lived. Yellow fever. The yellow fever is a mosquito-borne acute febrile illness. It occurs in tropical Africa and Latin America. It does not exist in India. The virus infection occurs in two forms: urban cycle and forest or sylvatic cycle. In the urban cycle, man serves both as a reservoir and as a definitive cases. The virus being transmitted by Aedes aegypti mosquito. In the forest or sylvatic cycle, the wild monkeys acts as a reservoir, and several species of forest mosquito are vectors. Human cases occurs only when human transposes into the forest or when mosquito raid villages. Prophylaxis, the control of urban yellow fever can be achieved by eradicating the vector mosquito. 2 vaccines have been developed for human use. The French neurotropic vaccine, darker produced from the infected mouse brain, carries a high risk of producing encephalitis in vaccine. A safe and equally effective vaccine is a 17D vaccine. The 17D vaccine is administered by subcutaneous inoculation. The vaccination is mandatory for travel to or for epidemic area, and it is valid for 10 years, beginning 10 days after administration of a vaccine. In India, the 17D vaccine is manufactured in the Central Research Institute, Kasuli. The India has a receptive area for yellow fever with a large populations of Aedes aegypti and non-immune individuals, but still yellow fever does not exist in India. The reason could be that the stray viruses may not be able to get established in the vectors due to the prevalence of Aedes aegypti of dengue fever viruses. Dengue is characterized by the fever of a sudden onset, headache, retrobulbar pain, conjunctival infections, pain in back and joints, also called as a break-bone fever, the lymphoadenopathy, and mucopapular rashes. It is endemic and often epidemic in the tropic and subtropical, particularly in Asia and Caribbean, the Pacific, and some areas of West Africa. In India, dengue is common in East Coast. Dengue virus has 4 serotypes: dengue 1, dengue 2, dengue 3, and dengue 4. It is transmitted by Aedes aegypti. Clinical picture: the disease may occur in 2 forms. Classical dengue fever. Dengue is more severe form with hemorrhagic manifestation. The classical dengue fever has a relatively benign course with fever, headache, pain, and muscles and bone. The fever is tropically biphasic, saddleback, and a maculopapular rash generally appears on 3rd and 4th day. The febrile illness lasts for about 10 days, after which recovery is generally complete. The dengue may also occur in more serious form with hemorrhagic manifestation or with shock. These are known as a dengue hemorrhagic fever and dengue shock syndrome. DHF, dengue hemorrhagic fever, and the dengue shock syndrome is seen in patients previously infected with dengue viruses or on reinfection with a different serotype. The dengue viruses antibody formed against the first viruses react with the second serotype virus, forming immune complexes. Virus antibody complexes. The initial symptom in dengue, hemorrhagic fever, and dengue shock syndrome are like those of dengue fever but associated with the hemorrhagic rashes, thrombocytopenia, and shock. The mortality rate is 5 to 10%. All four types of dengue viruses are present in India. Laboratory diagnosis: the isolation of virus is difficult, but serology play a major role in diagnosis. The demonstration of IgM plays in serum provides a early diagnosis. IgM antibody appears 5 days after onset of symptoms and persists for 1 to 3 months. ELISA is used for detection of IgM antibody. The detection of a four-fold rise in IgG titer is paired serum takes an interval of 10 days or more in is compulsory. ELISA is used for detection of IgG antibody. A strip immunochromatographic test for IgM is also available for rapid diagnosis. Detection of NS1 antigen can be done by immunochromatographic test. It is a rapid test and detects antigen on the first day of fever before antibody appears. The viral RNA can be detected in clinical research by reverse transcriptase polymerase chain reaction RT-PCR. Prophylaxis. The control measure includes eliminations of mosquito. No effective vaccine is available. Tick-borne flavivirus, tick-borne encephalitis virus, Russian spring summer encephalitis, Powassan virus, tick-borne hemorrhagic fever, Kaisarnur forest disease, Omsk hemorrhagic fever, hepatitis C virus. It has been described in hepatitis virus. Kainur forest disease. It is an Indian hemorrhagic disease that appears in Kaisanur forest of Karnataka in 1957. The birds and small mammals are believed to be reservoir of the virus. It is transmitted by the bite of tick. Hemophysalis spinigira. The monkey acts as an amplifier host. For many years after the discovery of Kaisanur forest disease, it remains confined to the area contiguous to the original focus in Sagar, Sorab, and Shikapur taluk of Simoga district in Karnataka between 1972 to 1975. A few other foci developed in the adjacent area of North Karnataka in 1982. A epizoic and a epidemic occurs in Beltangadi taluk in South Karnataka. The first human cases was seen in December 1982. Control of ticks. Vaccination. The population at risk should be vaccinated with the killed KFD vaccines. Personal protection of individuals by adequate clothing and insect repellent. Bunia viridae. Morphology. Virus belong to the family Bunia viridae or spherical 90 to 100 nanometer diameter. They contain a single stranded RNA genome and possess a lipid envelope with glycoprotein peplomer. Classification. Bunia viridae contains 4 genera. Bunia virus is a mosquito borne. Filbovirus is a Plibotomas or mosquito borne. Nairovirus is a tick-borne, and hantavirus is a non-arthropod borne. Viruses of Bunia viridae. Bunia virus is a California encephalitis virus, La Crosia viruses, and Citur virus is a Plibovirus is a sandfly fever, Plibotomus fever, Rift Valley fever. Nairovirus is a Crimean Congo hemorrhagic fever virus is a Gunjam virus is a Gunjam virus is a Hantan virus is a Belgrade virus is a Seoul virus is a Pumala virus is a Muto Kayon virus is a Sin Nombri virus is a Rio virus is a. The family Rheoviridae contains 4 genera: Ortho Rheoviridae, Coltiviridae, Coltivirus, Orthovirus, Coltivirus, Orbivirus, and Rotavirus. Only Arbovirus causes arthropod-borne infections. These viruses differs from other arboviruses in having both double-stranded RNA genome. The Colorado tick-borne virus is the only recognized pathogen in this genus. It causes a Colorado tick fever and is spread by wood tick, Dermacentro andirosoni. Rhabdoviridae. The Chandipur viruses belong to the genus vesicular viruses of family Rhabdoviridae. Was isolated in Nagpur, India in 1967. The vector or sandfly Aedes mosquito, in which viruses multiply. The pathogenic role of Chandipora virus is not yet fully established.